All right, team. So today we have three slides actually, or three ventilator interactions that were sent by Ariel Garnero, and so I thought that these were good examples to talk a little bit about breath sequences and how this can help achieve synchrony or discordance at the same time. So let's get started. Today is July 12th, 2022, and these are SEVA VentRounds. The disclosures, as usual, we will discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. I get fees and royalties from books, chapters, lectures, have a patent and consult for these companies, as well as Rob here, his conflicts of interest. Again, this is our opinion, not endorsing anybody. The ground rules, remember this is a recorded session, so keep your microphone muted, just because the background noise not good. The moderator, I or Rob may call on members of the audience to comment, or if you want to comment, just put it on the chat. Put your questions, we'll try to answer them as they come. This is a safe space. We continue to learn every day whenever we do these things. It's really impressive, all the stuff that we have learned from this. And Cleveland Clinic employees can get CME from these events. All righty. So this is the first waveform that we have for today. I wonder if there's any of the attendees that wants to give it a try and read this waveform. Patrick, you want to give it a try on this one? Or anybody else? It's I know that sometimes it's challenging to unmute. All right, I'll warm you up and then we'll answer questions as they come. So the first and we did a little bit of cheating, and I put here pressure control, and actually that's not cheating. It's actually good to have what the manufacturer name they use, but remember that what they put here not necessarily mean that it's exactly what the ventilator does. However, under this circumstance, the tag for this, you can use either the Vent Mode app that it's out there that has all the taxonomy, or we can do it just by looking at the waveforms, and that will also help you do it. So just for the sake of the exercise, we'll do it by looking at the waveforms. So the first part of the tag, remember, is if this is a pressure or volume control. So which one of those two are being controlled? And under these circumstances, if we look at the flow, that's where my eyes always start. I can see that there is different waveforms, that they are not all in the same configuration, and this tells me that the flow is unlikely to be controlled under these circumstances. I don't see any geometric waveform, and more importantly, it seems that this breath over here that I have here, I'm going to label it breath number 1, and what would be breath number 3 seem as mostly passive breaths, and we can see that it has an exponential decay, and the curve for pressure, it actually looks as a square. So this is and Kunal put there pressure control. Absolutely, I think that you're right on. This is pressure control. Again, the flow is not being controlled, we're controlling the pressure. Even though you see all these aberrancies over here, we'll talk more about them, but in these two that are passive, you can see them, and then when you see the flow, none of them look. Then comes the breath sequence, and in terms of breath sequence, remember that the breath sequence can only be either mandatory or spontaneous breaths. It's either a mandatory, in which either the ventilator starts or ends the breath, or they can be spontaneous, in which either the patient starts and ends, starts and ends the cycle. So it triggers and cycles. So immediately you see here that when we see this breath in this ventilator in particular, will tell you if the machine is triggering or the patient is triggering. And they do that by changing the color on the waveform, on the whatever value it's being used. So you can actually see here that the trigger is set to pressure down here. And the pressure actually changes color. It's white here. So over here, it's a passive breath, so it's triggered by the machine. So this immediately becomes a mandatory breath because it's triggered by the machine. And in the next breath, you see that it's triggered by the patient. However, based on the curve that we see here, this is cycled by the ventilator. And we know that because the I time is identical to the one before, right? And the next breath is also cycled by time, so it double triggered, and you can actually see the I time here. So this is all the breaths that are triggered in this mode are mandatory. So that means that this is continuous mandatory ventilation. And finally, the last item is the targeting scheme. And sometimes when you see only one breath sequence, it's hard to ascertain what is the targeting scheme. So meaning how is the ventilator programmed to control and interact with the patient. And what we can see on this breath sequence is that the patient is getting a mandatory, and then the patient does an effort and double triggers the breath. And actually, the pressure looks lower than that is set on the prior breath, and this is probably because of the effort that the patient is doing. That's my possibility, but I don't see any other level of intelligence here. And we know that in pressure control on this ventilator, this is set point, meaning that we set the pressure above PEEP, we set the inspiratory time, and we set the respiratory rate, the rise time. We set everything. The ventilator has no intelligence, just does what we ordered. Rob, any comments or disagreements here with the tag?
No, it looks good. One thing is on the breath that you have labeled 3.
Yes.
It looks like there's a very, very brief period of zero flow.
Yes.
Which confirms that is time cycling. So even if that breath was patient triggered, you know it was a mandatory breath.
Fantastic. So and what Rob is pointing out is this little pause that you see. I'm going to amplify it right here.
There you go.
And actually, you can see it on this breath, which would be the second one, which is 2 breaths, one on top of the other. You see again that little pause, and again over here. And whenever you see that, that means that it's most likely it's time control that is controlling the cycling phenomena rather than anything else.
Just to say again, a spontaneous breath is both triggered and cycled by the patient. A mandatory breath is triggered or cycled by the ventilator, or both.
Perfect.
Those are key definitions for breath sequences.
Fantastic. Thank you, Rob. Then comes the load, and remember the load is when the patient is, if you remember your equation of motion, you have pressure on one side, and on the other side you have the characteristics of the respiratory system and and volume and flow. And so from the equation of motion.
Has 2 patients in the unit right now.
Thank you. So when based on the equation of motion and what you have, you're going to be able to define what is the load, if it's either elastic, resistive, or when there's a lot of PMOS or activity, you will not be able to see elastic or resistive. So luckily we have breath number 1 and breath number 3, and breath number 3, these are passive during inspiration, so that gives me a little bit more information. Although if you can imagine that you were only seeing this breath over here, then you would have a different assessment. But what I see is essentially that this is returning to baseline pretty fast, in less than a second, goes to baseline, which is usually a characteristic of elastic load. Although I do see evidence of PMOS on breath number 2 and breath number 4. So you could definitely say that there's evidence of PMOS on the other breaths. And then during expiration, what we're looking is how fast does it return to baseline. And the only one that I see evidence of effort here, I see effort here. So instead of decaying exponentially like it should, you see all this area, which tells me that there's effort. So I would say that mainly I'm seeing PMOS, and perhaps on this one, there is some evidence of passive recall, but this over here makes me think that there's effort throughout in many of these waveforms. So I'm gonna just say PMOS and elastic during inspiration. Rob, any comments there?
Yeah, it's not only is it effort, but it's effort in the expiratory direction, right? Because it's away from the zero line on exhalation. So that means the patient is trying to forcefully exhale, as opposed to, being away from the zero line on inspiration. That's patients trying to forcefully inhale. So direction makes a difference.
Absolutely. So in terms of what the patient ventilator discordance that we see is, if you think about the first breath, you don't see any discordance, but if you see the second and fourth, you rapidly recognize that the patient is triggering, and the trigger seems to be normal. I mean, it essentially, there's a drop in pressure, but rapidly pressurizes the system. I don't see any evidence of a missed trigger, or sorry, a false or failed trigger. And so I would say this is a normal trigger that is occurring here. The other two are machine triggered. During inspiration, there is evidence of work shifting in breath number 2 and breath number 4, and we know that by two features. The first one is actually the drop in the pressure, even though the machine is trying to pressurize the system with 10 centimeters above PEEP, and the PEEP is set at 5, so this should be around 15. I presume this number. The machine cannot pressurize. The patient is doing a high amount of effort, and you can see that because of the flow waveform. You can see the difference in peak flow from the passive breath to this one, and how it continues to do effort actually longer than the inspiratory time. So I would say even though the pressure doesn't drop below baseline, there is evidence of work shifting on this mode. And whenever you're in pressure control, work shifting usually manifests by larger tidal volumes than what you want, rather than drop below the baseline. But although it can happen, I mean, if you set the inspiratory pressure too low. And then there's the cycle, which what you will see is in this breath that there is an inspiratory effort. Actually, the effort continues longer than the I time, and so the machine cycles the breath. That's this drop in pressure that you see here. The drop in pressure is because the patient is doing so much effort that actually it drops the pressure from all the way here to below actually the baseline. So it goes sub-atmospheric, the pressure, because the patient is doing so much effort. And so this is if I would draw the inspiratory effort, probably the inspiratory effort looks more or less like that, this long. And so this is the machine cycled early. And so this is an early cycle, and that is causing, because it's cycling early, it's causing a multiple trigger or double trigger, if you an early multiple trigger under these circumstances. And then finally, during expiration, as we mentioned, you see the evidence of effort. You see the evidence of effort throughout expiration. And then I always like to see the volume waveform if I have it available. And it's actually pretty telling that you can see this is 1350 of tidal volume, and you can see that the patient is getting close to 1200 of tidal volume in each one of those extra breaths. And because it's breath stacking, actually this breath that is close to 1200, on top of that there's another one. So if you add this one on top of that one, this patient is getting probably, I don't know, around 1800 mLs of tidal volume and the machine is not alarming for that because it's double cycling. Comments, Rob?
Just going back to the trigger.
Yeah.
In this case, it's normal because the patient started the first breath of the dual breaths, or the stacked breaths, as a patient trigger. If that had not been white, if that had been a machine trigger, and then followed by a patient trigger, we would have classified that differently.
Absolutely. Yeah, absolutely. Then it would have been an early trigger if it had started by the machine and then the patient. Very good. So there's a comment from Ariel that the effort is so large that or so strong that even the patient doesn't release any of the flow. So actually you can see that there's the release, but it doesn't cross the baseline. So that's a good observation, Ariel. So the patient, normally you would expect whenever you cycle, that's the pressure would drop and there would be flow below this baseline and the patient would be exhaling, but it didn't even happen. The patient it's at the maximum of the effort for this patient and it doesn't release. So in summary, when I see this waveform, I say, well, it's pressure controlled CMBS with elastic load in those passive breaths, but really a pretty high PMOS during inspiration and exhalation. I can see those two. And then in terms of the discordance, the main thing that I'm seeing is early cycle with work shifting and expiratory work. So this actually would look like bigeminy on if you were looking at an EKG. It's a completely off rhythm. It seems that the patient is going at its own rhythm. The ventilator is doing whatever we set there at 15, but the patient is going completely off rhythm.
And the clinical message here is that the volume waveform is completely misleading.
Yes.
Because it resets. And so really that patient had those two peaks stacked on top of each other, as you indicated. And even if you had an alarm set, it wouldn't have picked up how bad this situation was.
Right. And this is actually a really good comment because it also makes you think about all these trials that we do in which we're focusing on tidal volume and you're charting, right? Or you're looking at the records that are coming from the ventilator. These would never, unless you had the ability to see the waveforms, you would not, the highest tidal volume that you would record would be 1300 or 1200, when in reality it's close to 1800. And so this is something that I think that it's eminently a technological solution from the ventilator companies to detect the desynchrony alarm and detect double triggering and alarm that the tidal volume is high based on what they're seeing. Very good. Questions from the team in the chat. I addressed the comment from Ariel. Any others? Very good. All right. So really interesting waveform, and the question here is, well, how do I approach it? It's usually that's the item that I would ask myself is, well, and I will return you to the way that we choose modes of mechanical ventilation is by doing what we call goal-directed mode selection. So as I'm looking at this, the first question that I always ask myself is, what's my goal? And if the goal is safety, that means that I want to protect the lung or maintain gas exchange, or if the goal is comfort. And if the goal is comfort, then I'm trying to achieve better synchrony and balance the work of breathing, which in this immediately you can see that none of these goals, safety is not being met and comfort is not being met. So if you choose safety, you would have to say, well, is there another mode that can achieve what I want to do? And most likely, based on what I'm seeing here, the answer is going to be no. There's, if you're trying to limit the tidal volume on a patient with a ventilator, you're going to fail with this amount of effort. And then if the question is comfort, meaning synchrony and balanced work of breathing, the answer is no. You can evidently see that the patient is getting work shifting and 2 breaths one after the other. So let's see, based on the series of pictures that Ariel sent me, I presume the next one that I'm going to show is the next attempt at dealing with this patient. So here we go. All righty. So this is the next slide, and I presume it's the same patient because it has the same PEEP and same oxygen concentration, but now it has been, the patient has been changed in mode. Now, before, you may recall, we had pressure control. Now we are on auto mode, and it's the type of auto mode that it goes from pressure control and it switches back and forth with pressure support and CPAP. Is there any of the our fellows that wants to give it? I don't see any of our fellows. They probably are on service. So let's read out this one. Rob, do you want to give it a try?
Sure. What's the tag? First of all, we can just look at this, and as we saw in the previous slide, that this is essentially pressure control, some sort of pressure control mode, and we know that because of we see in the flow waveform we have, looks like a couple of passive breaths and a couple of active breaths. The flow is all over the place, the volume's all over the place, so that's not volume control. Okay, now as for the breath sequence, we see here, apparently, we have 2 mandatory breaths and 2 spontaneous breaths. So that is by definition a form of IMV. IMV means you can put a spontaneous breath between 2 mandatory breaths. Now, going further, if we know this mode from reading the manual, or if we have the Rosetta card, we see that there are 4 different kinds of IMV. The first kind of IMV, the original one, you set a rate for the mandatory breaths, and that rate is always delivered no matter what the patient does. The second type of IMV, IMV2, the mandatory rate will be suppressed if the spontaneous rate is high enough. So that's good for comfort, because the mandatory breaths are typically not as comfortable as spontaneous breaths. So IMV2 should serve the goal of comfort better than IMV1. IMV3 does essentially the same thing, but it's based on spontaneous minute ventilation. And IMV4 is the same thing in the sense that spontaneous breaths can suppress mandatory breaths. If you have a scheduled volume controlled breath and the patient triggers it and makes such a big effort that dual targeting turns it into flow cycling instead of volume cycling. That's kind of complicated. But right now, we know that auto mode is IMV type 2, which means that if the patient's spontaneous rate is high enough, he'll essentially just be on pressure support. You won't see any mandatory breaths unless he goes apneic or is, gets sedated. Now, what about the targeting scheme? In this case, you can't really tell by looking at the waveforms, but you know by looking at the mode name that pressure control is set point targeting and pressure support is also set point targeting. So we have pressure control IMV type 2, S, S. Long answer. Okay,
Yeah.
so
Go ahead,
any
Rob.
comments on that, on the tag?
No, yeah, I was gonna just comment that in this case you have the patient, the mandatory, and you have the spontaneous. And so what you're telling us is that if the rate of the patient, the spontaneous breath, is high enough, then we should not be seeing the mandatory breaths, right?
That's right.
Okay.
But I would suppose that the mandatory rate is probably the number of breaths that you see, and the patient's rate is half the set rate. So that's why they're not suppressing the mandatory breaths. That would be my guess. So you basically get a mandatory breath and a spontaneous breath, mandatory breath, spontaneous breath. It looks like some sort of neurogenic breathing pattern or something. I don't know. That's something to think about. So the next question is, what is the load? And again, the analysis, if we're assuming this is the same patient, is the same for the mandatory breaths. We have a very quick drop in inspiratory flow to 0 during inspiration. That would indicate a high elastic load. And for the mandatory breaths, the passive breaths there, they appear to be mostly passive, except on exhalation. We'll talk about that. Then the spontaneous breaths, the 2 giant breaths, you can't say anything about the mechanics of that because the PMUS is so big that it's overriding that. What we can just say is that that's a huge PMUS as the load that the patient has to bear or is choosing to bear in that situation. As for triggering, and now we see that we've gotten rid of the double triggering, and that's because the inspiratory time is now being essentially set by the patient and not by you as the operator, right? So these are large spontaneous breaths that the patients are triggering. You can see that the inspiratory time, I would say that's 2.5 times the set inspiratory time on the mandatory breaths. And so now we have at least served the goal of comfort by allowing the patient to determine the inspiratory time when they make an inspiratory effort. So there's that. I would call that normal triggering now. Inspiration, again, because of the PMUS, clearly work shifting, indicated by a very high flow, high area under the flow, which translates into large tidal volumes. And so we see huge tidal volumes and little tidal volumes, huge tidal volumes, little tidal volumes, which you'd have to wonder if that's a comfortable way to breathe. Which I guess is a problem with all forms of IMV, at least pressure-controlled IMV. Cycling, for the mandatory breaths, the cycle synchrony is irrelevant because the patient isn't making any effort. There's no issue of synchrony there. As for the spontaneous breaths, these are flow cycles because it's pressure support. It's not clear what the cycle threshold is, but in pressure support, you set the cycle threshold as a % of the peak flow. So obviously, the higher the peak flow, the longer it takes to go down to whatever % you have set. It looks like in this case, it's pretty high. It might even be like 50% or more, right? Can't tell. But it appears to be either appropriate or perhaps a little bit premature cycling, early cycling, because we don't see a nice spike on the expiratory flow. Given that the tidal volume is so big, you would expect to see the peak expiratory flow to be big, certainly much bigger than the small mandatory breath, right? But they seem to be about the same. So there might be some evidence there, and where you, on the last breath, you pointed out there's actually a deformation of the peak expiratory flow. So I would say that's indication to me of early cycling. So the way to fix that would be to drop the cycle threshold, because the machine is trying to shut off before the patient's expiratory or inspiratory effort has shut off. And then expiration, again, it appears for the mandatory breaths, it's, well, for the first one, it seems pretty passive. For the second one, we have a little bit of PMUS on active exhalation. And certainly for the 2 spontaneous breaths, there is active exhalation. So this patient has a very strange breathing pattern. I think that's it. What do you think?
Yeah, I think that very large tidal volumes. I will point out that now that the patient can take the breath on its own, you see that it's closer to the 1900, the tidal volume that we had calculated before. So now each one of these breaths is huge, and then the patient seems to shift from active inspiration to active exhalation. And instead of having that decay, you can see how there's this effort. And actually, it flattens out, like if it was bearing down continuously. The machine delivers these 2 breaths during active exhalation, and that's probably why it looks like the elastic load is high, because it's what the...
Yeah, that's right. That's right.
And so then the patient continues to do effort, and so the tidal volume is still there. So, and actually you can see here's during exhalation, the patient is actively exhaling, and then they get this inspiratory effort. So I think that without a doubt, very high inspiratory and active expiration. And when I see this flattening of the flow curve, it makes me think if there's obstruction in the patient, that there's a sort of flow limitation, and the patient cannot get through, and so it cannot achieve the aim, which is to breathe the air out as fast as they can because they have obstruction. That's what it makes me think.
They could probably feel that. Maybe he just needs to be suctioned. Who knows, right?
Mm-hmm. Yeah.
The thing is, these mandatory breaths, as you point out, they're not doing anything for us.
No.
So that would indicate that maybe what you do is either get rid of or probably turn the mandatory rate down, right? So
Right.
they're not interfering as much, or just put the person on pressure support, straight up pressure support, if you're not afraid of them becoming apneic.
Right. So that's great. So again, if we look at our goals, if we think about the goal of safety, meaning that the patient is going to have appropriate gas exchange and prevention of ventilator-induced lung injury, we are not achieving that here. I mean, right? And if we think about the comfort item, we have improved somewhat. Now we have a decrease. I mean, we took away the cycle, perhaps some issues with cycle synchrony, but it's much better than before. But we're still with a degree of work shifting, and then there's these breaths that are not doing anything for the patient. So
I would agree with what you said before. There's probably no mode that's going to help you here.
yeah.
You have to turn your attention to why is this patient doing this physiologically? What can we do to address his need? Maybe, like you said, maybe he just needs to be suctioned. There might be some obstruction in the tube.
And that's why having the goal, and I mean, whenever we do this goal directed, the first step is to know the diagnosis. The second one is to know what your goal is, and the third one is to choose the mode. So here, obviously, we're missing the diagnosis, but I mean, we're just working from the example of having either a goal of safety or a goal of comfort. And I presume this is the third example, and this came from, it's the same patient. You can see 30% and 5 PEEP. And so let's read this out. So again, I'll just, for the sake of our discussion, we started with pressure control CMB. So all the breaths were mandatory. Then we changed to an intermittent mandatory ventilation breath sequence, one that is supposed to be suppressed whenever the rate is faster than the one that we set on the ventilator. And then, as we discussed, this was not cutting it, and perhaps we could have reduced the respiratory rate on the ventilator. That would have done it. But the patient was changed to pressure support, and that's fair. Under these circumstances, that's something that you can do. And so let's read this one. All right. So
how about Ariel? This is actually a slide.
Yeah. Ariel, do you want to read this slide?
Yeah, I got no problem.
Okay, so what's the tag?
Well, this tag, it's a control variable is pressure. The breathing sequence is only spontaneous breath. We can see that they are patient initiated and cycled by flow. The I time seems to be pretty close, but slightly different. There's no mandatory breath present at all, so I would assume that based on only these 3 breaths and knowing the name on top of it is PCCSV, and that targeting scheme is set.
Set point.
Set point. So the whole sequence we've seen, it's really sometimes we have to ventilate patients with a respiratory drive, mostly after cardiac arrest, that they are taking huge breath and a slow respiratory rate. This patient ended up with a rate of 8. And the main concern, since the patient couldn't be paralyzed or P mass very diminished, was if we cannot avoid PMASC, we have to go with the drive and make the breath as comfortable as we can. And we knew that the mode had to be pressure support. The point is now how much assistance would be able to prevent a huge work from the patient, and at the same time, not encouraging on top of the pleural pressure a higher level of positive pressure. This vent doesn't have automatic tube compensation, but I had cases like this before that I ended up ventilating them with CPAP and automatic tube compensation only. It was seeing the patient breathing, it was like literally taking a huge breath, and we couldn't do anything. I mean, when I received the patient on pressure control, I knew right away that we couldn't use any breath, any mandatory breath at all, and we couldn't impose any breathing as it was seen before with the mandatory breath in between. So the only option here was try to make the patient as comfortable as we can, and pray that the large data volumes didn't have any consequence. That's the only thing. It was sad to see, but we couldn't do much more than this at this present time.
And Eduardo, do you think there is a risk for a post-op or for a post-cardiac arrest patient with normal lungs to be breathing tidal volumes this big?
So, I mean, the question, I don't know I can completely answer it. I think that I always think about the lungs as at risk or without risk, right? So if they're at risk because of the milieu, because they aspirated, because you have pneumonia, because of neurological injury, whatever you want, then you're always concerned that there could be injury from the transpulmonary pressures because of the large efforts that the patient could generate. And so, but at the same time, you have to make a decision on based on the whole patient, not just on the lungs. And so, when what I'm hearing from Mireles is that the team, I mean, the amount of gas exchange abnormality seems to be low, very low PEEP, and the oxygen concentration is 30. And I don't know, it's 30 because of the usual inertia to go below 30, or it is because the patient needs 9% extra of oxygen being inhaled. So if the gas abnormalities are low in a patient like this, and the overall is, well, we want to see where the brain status is. I may side with I probably would side with the goal of comfort on this patient and saying, well, this patient, just minimize the amount of pressure that you're giving and let them breathe on their own rate and rhythm. And many times this group of patients with neurological injury only have the AT tube, not necessarily because of the gas exchange abnormality, but because of the need to protect the airway. And so, which would, if the patient didn't have an endotracheal tube and was breathing like this, you probably would not, you don't do anything. You just look at the patient and say, okay, sleeping, let him be. But because we have the ability to monitor and see the value, you sometimes start doing actions. And I would say that in a patient with this amount of gas exchange with neurological injury, where prognostication is probably better and not muddying the waters, I would side with comfort and letting the patient breathe on their own and remove that tube if I can. I would say that just in the sake of reading this waveform completely, that what you see is it becomes much clear that this is only PMOS, right? A real high amount of PMOS during inspiration. And during expiration, there's also activity of the expiratory muscles, which may be causing those aberrancies on the peak flow that we're seeing. And now the trigger is completely normal. Although I would say that you can see how much it drops the pressure for this patient. So it's a really tonic activity. It's like it goes rapidly with a very deep, long effort. You can see still the work shifting. And actually now, because the pressure that Ariel put him on is relatively low, it almost tries to go below baseline there, right? And the cycle to me looks still normal. I would say that it's crossing immediately. And actually this rise on pressure makes me think all this area over here that the patient is actively exhaling on the circuit. So I think that there's expiratory work with normal circuit. And so I would say that under this mode, my goal is comfort, and we are better, at least visually, and I know what exactly the patient is doing compared to before, than on pressure control. You could say, well, you didn't change much. The patient is still doing whatever he wants, but at least now I know the truth, rather than before that I was seeing extra layers there. That's my thoughts.
A really great analysis. Thank you.
Okay. Questions from the team, comments? I would highlight, and this was interesting. I mean, that's why I cut this area so that you could see it. Look at the dynamic compliance according to the right. Isn't it psychotic? So because the ventilator is essentially not providing any support, the ventilator is calculating the compliance for this patient as 300, which it's pretty unlikely to be the case.
Yeah, they should have some override algorithms in there that say don't calculate dynamic compliance if you have a PO1 greater than some number, right?
Right.
Because again, the ventilator doesn't know the difference between a high compliance and a high effort. It all looks the same to it.
Very good. All right, team. This is it. This was thank you, Ariel, for the images. These are very educational and appropriate, and you can see the effect of sequence and how we would using a goal-directed mode selection, looking at comfort or safety, how you end up adjusting a little bit more the ventilator until you achieve what is most appropriate for the patient under the clinical goals of the whole team. All right. I hope that you all have a great summer, and thank you for all. Bye-bye.